Dilip, is what you need to select. We
Except
haven't gone
me.
live yet. Yeah, sure. And then is it full screen? Are we full screen?
Yes, we are
Yes,
full
we
screen.
are.
Now,
Okay.
now it is.
It is full screen, right? Yeah.
Yes, it is full screen.
Yeah. Just a couple of seconds more and then I'll be going live.
Yes. A very happy afternoon, morning, evening, depending upon the part of the planet from which you have logged on to this webinar. A warm welcome to ASPA FLEX indeed. As you know, ASPA FLEX, or ASPA as such, is committed to learn and teach, and we are so pleased you all are here. But let me introduce myself to begin with. I'm Dr. Brushali Ponde, and I am the lead for this webinar. I also serve ASPA as the education lead. In nutshell, I am totally responsible for making this beautiful team slog for a couple of rehearsals and present this webinar to you. Well, a bit of a humor apart. So today's webinar is all about skill up with simulation. It's a case-based learning. Simulation as such has a ubiquitous influence on teaching and learning in today's day and age. However, this is the first time that we are attempting a totally virtual simulation program as such. And yes, we are pretty excited about it. Now I have this pleasant responsibility of introducing the entire team to you. So this is me, and I skip me. I just told you who I am. And I go to Sarpil. Dr. Sarpil is the co-lead, the partner in crime, as it were. She is a professor, associate professor, Department of Anesthesia in Asatabin, Istanbul, Turkey. She is the president-elect of ASPA. Having said that, she's an extremely dear friend. Coming to the simulation facilitator, well, I introduce you Dr. Vaibhavi Upadhyay. She's a clinical lead in simulation. She's an anesthesiologist, first of all, and she works in Dinanath Mangeshkar Hospital here in Pune, which is India, Maharashtra. She has worked in simulation day in and out, and you would see how smooth she is. Let's get you to another panelist, Dr. Ravina Ali. Well, they have a very common forte to work in. Ravina is also a ardent simulator, and her forte is teaching through simulations. Again, she's an associate consultant in Hong Kong Children's Hospital. She's a lead of work group in multidisciplinary training on perioperative crisis management. She's a simulation instructor, and she has wonderful interests such as pediatric anesthesia and perioperative allergies. I present you the next panelist, who's Dr. Dilip Chavan. We have worked together hand in hand for almost more than a decade. He's a director of Children's Anesthesia Services, co-program leader for the fellowship in Pediatric Anesthesia World Federation of Society of Anesthesiologists, along with CAS, and a co-author of a couple of books. His, of course, interests are pediatric airway, regional, and vascular cannulations. We get you to another panelist, as well as the most competent IT support. She's going to hold us through here. So she's Dr. Vibhavari Naik, and she is a senior consultant as an onco-anesthesiologist in a very well-known hospital in Bangalore, which is Basavataran Hospital. And she is managing the IT support for ASPA FLEX for quite some time now. So now what I do is I give you the gist of what this webinar is all about. So we are scaling up, as I told you, with simulation. So we get introduced to Mentimeter and the trial run through it, and that's going to be done with you by Dr. Vaibhavi. Mind you, this is my job to remind again, please keep two gadgets ready. One is your cell phone and another is, of course, laptop, so that cell phone can work with Mentimeter, and she's going to very smoothly take you over through this. And of course, we are going to have two cases to begin with, and those are extremely, how should I say, intriguing, and that I'm sure is going to keep you on the edge there. Well, do not please forget about the question and answer sessions, which are in the Zoom. So you have two platforms. One is the Mentimeter, another one is the Zoom. Those who can't by any chance go through the Mentimeter, they can always tell us their thoughts through the questions, or they can comment through the questions, so that we as panelists can pick up and get on the suggestions that you want to pour in here during the panel discussion. So this is about question and answers through the Zoom. Now the certificate of attendance, that is something which ASPA loves to do, because we like to take the post survey. This gives an impetus for us to look back, reflect, and see what better we can do here. So we automatically generate a feedback form. Please fill it, give it to us, and then the certificate of attendance shall be emailed to you by tomorrow. So now at ASPA, we offer a lot of things here which are never under the wheel of your credit cards. Go to YouTube, and all our previous webinars are available. You can follow us on Facebook. Please visit our website so that you really come to know what ASPA is about and what ASPA can offer in pediatric anesthesia education, what you could offer to ASPA as well, of course. So now there is a disclaimer here. There are certain launching pad videos which are put up here. Mind you, there are certain fallacies which are being incorporated in the videos so that they can work as a launch pad. So please do not judge the acting, the actor, and the content of the videos, and enjoy the webinar as well. As of course, we are all going to learn from it in loads. So are you ready to be ready so that I can hand you over to Dr. Vaibhavi, who's going to take you on the journey of simulation henceforth. Over to you, Vaibhavi.
Thank you, Dr. Rushali, and welcome everyone to ASPA FLEX webinar. We do have 2 cases lined up for simulation, and there is a wonderful platform I'm going to introduce you all to called as Mentimeter. It is in short called as Menti as well. So today's start is basically to know your Menti. Okay, so let's begin to know how your Menti is going to help you. So for that, I'm going to actually take you through a platform which will help you as participants, at the same time, the facilitators and the panelists to know each other, to interact with each other through this platform. Okay, so here we go to know our Menti platform. It is an interactive platform, like I said, so that we as panelists and facilitator can chat with you, and you can chat absolutely every aspect of the queries, the answers through this platform. And it's wonderful. I mean, I know you may ask me why not Zoom, but you will know soon the beauty of it. As Dr. Rushali mentioned, there are 2 devices that may be required. One is on the laptop where we are entering through Zoom, through the webinar link that you have just entered ASPA through. At the same time, on the smartphone, I would request you to actually open menti.com. As you can see on the top, there is an instruction on this slide. And this website, enter the code that needs to be, a numeric code. Once this is done, there are some times when, let's say, you don't have 2 devices. What can you do? It is possible to use a single device as well, where you can toggle between the Zoom and the Menti. Okay, you can toggle between Zoom and the Menti. It is possible to do so. All right, the next one. Let's begin our journey here. I would request all of you to use this QR code and scan and go and enter menti.com, or you can go to Google and type www.menti.com, enter this numeric code, so that whatever slide I'm going to show you on here, Zoom, you can see it on your Menti as well. You can answer the questions that are going to follow through. So here goes my first question. Please name the country you're from. There is a QR code at the bottom left if you need to scan it again. Fantastic. Oh, wow. I mean, this is amazing. Welcome, everyone. There are people from all over the globe, I must say, and it's a pleasure to be your host today. Amazing. Thank you, everyone. Thank you and welcome. If you note, you could actually enter a single answer, because after that, the Menti must have said, okay, that's it. One single answer is allowed. But this is just one aspect of Menti. What I'm going to do is I'm going to take you to the next slide to explain a particular aspect that may trouble you. For example, I have changed my slide here, but then your Menti might still lag and be on the previous slide. Just in case this happens, do not worry. Just see something called as go to slide. As you can see on this photograph, you can click on that and Menti will take you to the most recent slide that is seen on Zoom here. Okay, so no worries if you lag behind. Go to slide or the next question or refresh. These are the 3 words. You have to just find it and click on that for you to catch up with me. There are also certain emojis that you can see on your slide, and I can see that already there are many emojis which are being clicked, and there is, I can see one thumbs down as well. If you're still struggling, please listen to me how to go ahead using it so that it will ease you to, use Menti. So the next question, how are you all today? Okay, how are you all today? And if you note, this is a slightly different way of answering. These are multiple answers. There's no limit to it. You can answer as many words as possible. Yes, how are you all today? How's your day going? It's a Sunday. It's a beautiful day, I must say. Yes, it's excellent. And you're ready to listen. I can see that too. Very well. Thank you. Thank you. So I guess all of you are able to answer through Menti, and I can see that many inputs coming. Almost 66 people have been able to enter the details. Just in case anybody is still struggling, I'm sure as time passes, as you understand, you will be able to go through. Okay, so now I take you to the other aspect of Menti. Okay, right, just a moment. Okay, now apart from the answers, the presentation might have certain images, certain videos, and if you like them, you can actually use the emojis like a thumbs up, heart, a question if you have some. You can just keep telling us how you feel through these emojis. Now, there is a question again. Do you love to take care of pediatric patients? Okay, do you love to take care of your pediatric patients? And if you notice, this is a kind of an MCQ. It is like choose one answer from the multiple choice question. And that's how it will be flashed on the screen. It's a pie chart, and that gives you an answer, which tells you, it tells us all together what is the collective opinion of the audience today. So if you can see, 70 people have commented and 89% say that yes, they love to take care of pediatric patients. There are 8 say no comments. Maybe they are still not into pediatric practice. And they're certain they say no because there may be a fear, a concern. We don't know. We'll see as time comes. Okay, so this was MCQs for all of you. So what is it, if I may ask, that you love about taking care of pediatric patients? Now, the answer to this question is going to come slightly in a different way, because I'm sure you have on the Menti a set of questions that will give you a space to write the answer to this. The moment you write the answer to this, it will scroll as it comes. So I would request all of you to type your answer here. Okay. Yes, they are difficult and they are exciting at the same time. They're cute and innocent. I know. I love children too. Okay. I love the pediatric bench. I so relate with you all. Yes, it is satisfying and grateful, to do this. Yes, so wonderful. I mean, it is something that, makes us sleep well at night. It's something that gives us so much satisfaction. And I know they come smiling to the OT, and then seeing them pain-free is amazing. Thank you for all these comments. Now, as you see, this scrolling up is something that we can actually use it during our panel discussion. So our panel can actually interact with you all, and we can talk to you through this, and you can talk to us through this. There's one more interesting thing, okay? Because we can talk day and night. I know we love to talk, but there is going to be a time limit. So there's going to be a voting countdown. There's going to be a time limit for each slide so that we respect time, yours and ours as well, okay? So the voting will close after the countdown reaches 0. And that's how we will know it's moved to the next slide, okay? So this is one introduction. And the second, if you see there is on the Menti slide, you will have a small comment section, okay? This is a sign on the right-hand corner of my screen that you can see on your Menti. And there are already some people typing amazing, mind blown on that, but you can type your own personal comments as well. Yes, can you see that it's coming here on the screen? It's a brief, momentary comment that comes in. So all the questions asked, the answers which are relevant to the questions need to come here as a scroll down. But sometimes if the comments are not related to the question, but it's just something that you feel you need to tell, is where you can use the comments on the right-hand corner and at the end of your screen. Okay. All right. So now we go to the next aspect, which are the videos that will be projected on Zoom and not on your Menti. So if we show you some video, it will be on the Zoom platform and not on your Menti. But on your Menti, of course, you can type the emojis that, do you like that video or do you like that image? You can tell us that. I can already see that coming from here. Now, as Dr. Rushali did mention, there is a disclaimer. All the videos which are recorded by our panel have a kind of, you can say, intentional performance gap for us all audience to recognize and to learn from that, how to prevent it for future. So please do remember, these are videos made for educational purposes. Now, I'm sure there is a question amongst all of you that just in case my Menti doesn't work, and is there a way I can talk to the panel? The answer is yes. Through the webinar link that you have joined, there's a Q&A section. You can use that, but preferably use Menti because we need all of us to be on the same page, as we say. So coming to Menti as a single platform will help us interact much better. But yes, just in case there is an issue with Menti, you can go to Q&A. Our panel is going to watch the Q&A as well and get your queries on board for discussion. Okay. As the presentation ends, your Menti might show you this sign. It would tell you that, what do you want us to do? Please click on join another presentation, because after this introduction and orientation to Menti, I'm going to take you through 2 cases, one after the other. And both the times, the numeric code is going to be different. So you may have to re-enter the code for every presentation. So just to summarize for all of us, what is Menti going to do for you? You can vote through Menti, you can comment through Menti, you can express your emotion with an emoji. You can answer the questions that are asked on the screen, and lastly, discuss with the panelists using the scroll up and down mention. What will Zoom do for you? The Zooms will allow you to watch all the videos that are streamed, the images that are streamed, but also there is an option of Q&A, which can be used if the Menti gives you an issue. Okay, I think everybody is clear by now. So, are you all ready for virtual simulation? Tell me, come on, show me some energy. Yes, okay. Okay. I love the multiple S in the yes. Okay, so there we go. We are going to start our first case, the simulation. Okay, I'm going to take you to the first slide. Okay, there you go. All right. Okay, just give me a second to make sure nothing comes in our way as we. All right. So let's start our day. Now, here we have used the word mistakes that we don't want to make. But please do remember, simulation is a place where, frankly, mistakes are okay and we learn from them because that's a learning opportunity. So through simulations, we are going to learn from our mistakes. Okay, so this is the 4th ASPA FLEX 3 webinar, and we begin our first case scenario. Okay. The theme for this session is vagaries of prone position in anesthesia. All right. The case scenario is so: a three-year-old male child who is weighing 15 kilos, diagnosed to have medulloblastoma and undergoing a posterior fossa surgery in prone position. All right. So let's look at what really happened in this case. I request all the participants to very intently watch this video, because the more intently you watch, the discussions that will follow, the debrief that will follow this video is going to be what we are going to learn from. So I need all of you to watch it so that we can really interact with each other.
Hi, this is a 3-year-old, 15 kg boy diagnosed as medulloblastoma, undergoing posterior fossa surgery. Let's see what happens. Stop.
Madam, will we give ceftriaxone for this patient?
Yeah, we did.
Can we also give vancomycin? I'm anticipating a lot of infection as it is a redo surgery.
Okay. Nitya, we need to give 20 milligrams per kg, which is 300 milligrams of vancomycin. Can you load it for me? Sure.
I think the blood pressure is going down. Nitya, can you load up some noradrenaline?
Yes, will do.
The heart rate has also started going down. Is everything okay on the headache?
Yes, ma'am. Everything is fine. Is anything wrong?
The heart rate is going down, the blood pressure is going down. I think the child is going to arrest. Nitya, can you just call for help from the other OT?
Okay, everyone, how did you feel as an emotion while watching this video? I need you to introspect and think of what this video made you feel. Yes. Yeah. Makes us feel worried, terrifying, at times annoyed as well. Stressful, yes. As you can see, there are myriad emotions that come into play the moment we come across a critical incident, a crisis in healthcare. And these emotions are truly the ones that actually prevent us from truly taking the right decisions. It cognitively can overwhelm us many a times. Please do remember these emotions are normal because we are human beings after all. In fact, naming the emotion that you're going through and acknowledging it and saying that I'm scared and it is okay to be scared during the crisis can actually help us, overcome the cognitive overload. Please try this mindfulness exercise, and it works for us to overcome all these emotions to truly take care of patients effectively. Okay. So once we acknowledge these emotions, we go ahead and look at, in this video, what all went well. Here, I give you approximately 30 seconds to answer this question. The team communicated. There were clear instructions that were given. Okay. Yes, we may feel sometimes nothing, that nothing went well, but truly think about, are we being too critical about, self-critical about us? In any possible incident, if we look at, there are certain things that are done well. If we truly look at them, the morale of the team remains good during debrief. Otherwise, if we just look at what all things did not go well, I think we may not come to work the next day. So at times, having a look at the positives is a good idea to do so with our teams. Yes, the instructions were given, the call for help was called, there was vigilance amongst the team. And the voting has closed, so that tells us that we need to go to the next slide. Now, the next slide is what was challenging. Now, challenges are not negative, okay? They actually tell us that there was a challenge and it is time we overcome it. It gives us an experience to overcome a challenge, and that's what a learning opportunity is all about. So let's look at challenges from few angles. One, what was a personal challenge? Yes, from the patient, from the team, from the systems. Yes, the condition deteriorated really bad, like really quick. It was rapid. The patient was prone. Yes, it was a challenge. The patient also had probably, hypotension in a prone position, arrest. Okay, absolutely. I guess I can see a prone in capitals, which means that is something that weighs on us largely. Prone position, making CPR difficult. Yes, there are challenges which the team faced here. But what we are going to do now is we are going to look at the first question. Should the team be resuscitating the child prone, or should they turn the child supine? What do you all feel? Okay. What is the scientific evidence to tell us how do we resuscitate? I can see there's an equivocal turnaround of the pie chart, and everybody is contemplating what to do. And of course, as per the scientific evidence, which we see is, continuing the resuscitation prone is something that is advised, provided, the surgeon is, if in case the surgeon is the middle of surgery, supine, making the patient supine is a bit of a challenge, but resuscitation should begin as soon as the crisis is detected. Okay, so let's go to the why. Why should we perform initial resuscitation in prone? I mean, there should be some scientific reasons for the same as well. For this, I invite all the participants to write the reasons that appeal to you, that why should we resuscitate in prone and not really flip the patient supine immediately. And I would request the panel, Dr. Vibha and Dr. Rushali, to interact with the participants regarding this.
Yeah, thank you, Dr. Vaibhavi. I think a brilliant start, and it's just lovely to see so many people giving answers. And I think what they are writing is what I would agree with, that we need to have a quick response. We do not have adequate time to turn the patient supine. We need to reduce the no-flow time to optimize the chances for resuscitation. Also, turning supine is a little challenging, isn't it? Like you said, the surgeon would need to cover up the surgical area. We need help to turn. The child has pins put on probably. So we have to take care of the lines. We don't want to lose a center line just by hurriedly flipping this child. So I think it is important that we start prone, but how do we do it? This is a 3-year-old 15 kg child, so probably one hand compressions over the midline, that is the spine, a little below the angle of the scapula is how one could start. It's important that there is some firm support, either a bolster, or maybe you can put your fist, the non-dominant hand fist underneath while you give chest compressions. And in other prone position situations, say, what if it was a spine surgery? Then instead of midline compressions, you could go ahead and keep 2 hands on either sides of the incision to do it. In fact, you know what, Dr. Vaibhavi, even a lateral resuscitation has been described in literature with positive outcomes, and that can be done by using 2 fists, one on either sides, to give chest compressions. Also, I feel that we have an arterial line in place, isn't it? We have ETCO2, so we can watch them to assess the efficacy of resuscitation. So trying to maintain a diastolic blood pressure above 25 millimeters of mercury if it is an infant, more than 30 millimeters of mercury for a child, and keeping the ETCO2 above 15 millimeters of mercury is what is recommended. And in case you are not able to achieve this, which means that probably the CPR is not as effective, then you may consider turning the child supine. Anything else Dr. Rushali wants to add in?
Yes, actually, if you see, the audience is pretty astute. They have almost covered all the points, and they have also mentioned time in and again that we need to turn the patient supine. So they're pretty interesting, how should I say, distribution of ideas which have popped up here. So let's go one by one. Yes, Vaibhavi, we have started the resuscitation, and the resuscitation that you have described is obviously going to yield results. But I guess we need to look at the cause. Given the surgery that is happening in this particular scenario, the most important cause to rule out could be a sudden blood loss. So meanwhile, while we are resuscitating, think of that the final answer would be a rapid blood transfusion. And of course, once we are stable, go to prone position. I mean, change the prone position to supine and carry on with the resuscitation if it has not yielded results. Otherwise, we can continue the way it is. This is what I would add on this.
Absolutely. I think pretty much the audience has put in most of the points, and a brilliant aspect that Dr. Vibha and Dr. Rushali has brought in about knowing what situation we are, what situation the surgery is, what point of surgical exploration we are in. And if it's about CPR, it is possible to give CPR in prone position. We just need to know what are the techniques. In fact, we could achieve the best ventilation perfusion in prone position if we can resuscitate fluids and blood as in when, because the ventilation is optimized with a secured airway and the prone position already. So thank you, panel, for the questions, for the answers, and the audience as well. So it's time for us to move to the next. Now, this did happen, but let's think of what were the differentials in diagnosis that you want to consider. Why did this happen? What went wrong during this, and what was the cause for that? I mean, why did the child became almost near arrested? For this, I would request the panel, Dr. Serpil and Dr. Vibha, to interact with the participants as they type in all the thoughts.
There are interesting answers. So yes, this can be an anaphylactic shock. And we are in the prone position, and this is neurosurgery, so air embolism is to be put in the differential diagnosis. And all notice that the assistant is giving the drug so quickly, so the speed of injection of vancomycin is of concern. And almost most of the audience is putting into air embolism and anaphylaxis. Vanco reaction, guess these are all the points we have to consider. As Rushali has said, bleeding, but the surgeon says that I'm all right. So there is no suspicion of bleeding. The wrong drug, if the assistant is taking out the wrong drug, but she says that she's giving the right drug. So what else can you think, Vibha?
Yeah, I was just thinking that since it's a neurosurgery prone position, do you think brainstem stimulation could be one of the reasons? Like when they handle the vital areas, the vagal nuclei there, we can see bradycardia and hypotension out there. And rarely though, but sudden loss of CSF can cause reverse herniation of the brain and can also cause hypotension, bradycardia. But I think they've really put most of them there. If we are running any concomitant medications, like sometimes we do give propofol, dexmedetomidine, or even phenytoin, if it's given a little fast, though not for an intratentorial surgery, but these are some of the reasons which can aggravate the hypotension and bradycardia that can occur in neurosurgeries. I think the most interesting one was the vancomycin as the answer. So could we explore this a little bit more, Dr. Vaibhavi?
Absolutely. I think let's go to the next slide. And I will be happy to ask you, do you know about vancomycin-induced red man syndrome? I could see few comments there which did mention that, but I just want to clarify once again that have you just heard about it or you know it in details? Okay. Brilliant. Okay, I'm just going to give you 30 seconds to answer this. I need all of you to answer this because I will know what is it the audience knows about the red man syndrome. Okay, so 64 people have commented. I would request all others who are there to comment as well. Okay, somebody has already seen a case happening in their real practice. I mean, this is like truly something that can happen. Yes. Fantastic. I think the voting is coming close. Okay. Just one more second and then we go to this. So as we can see, 39% of people have said yes, they know, they've heard about it, they've seen some cases. 21% says no, we are not aware of, and 39% says they have just heard the name, but they really don't know details about it. So let's look at how we can know more about it. There are certain articles and case reports which have seen vancomycin-induced red man syndrome right from infants to adults. This is a paper, a reference which you can refer for reading more about it. But at the same time, the term red man syndrome, because there's a red rash, and these are all the dermatological findings in patients varying in age, gender, and different skin colors, and how this presentation looks like. Okay. So my question to all of you that you have heard about it, but do you know any other names with which red man syndrome is addressed? Okay. Do you know what are the other names which are commonly used for this? And I would invite Dr. Vibha to, enlighten everyone.
Okay, so yeah, I think already a few names have started coming in. You've already mentioned red man syndrome. I'll just take you through the historical perspective. So long back, it was called as Mississippi mud syndrome. So that's because vancomycin was called as Mississippi mud because of the brownish discoloration. And it was thought that there were many impurities that led to this reaction. But eventually, as more and more pure versions of vancomycin came, the reaction still stayed. And that's when the terminology red man syndrome came in. But like Dr. Vaibhavi said, it's not appropriate because the redness may not be seen in some patients because the skin is colored. And now in the literature, probably the most commonly used terminology is vancomycin infusion reaction, though there are other names like vancomycin flushing syndrome or vancomycin anaphylactoid reaction. So these are some of the names.
Absolutely. Thank you, Dr. Vibha, because we need to have a single name for the single, reaction. And hence, vancomycin infusion reaction is a most appropriate scientific name given to it. So why does this happen? I mean, why does vancomycin infusion reaction manifest? What is the pathophysiology? So here we have approximately 30 seconds for the participants to think about why this reaction happens. And the panel is Dr. Rovina and Dr. Dilip.
Yeah, so basically, most of these people, all of them have told the answer is about the histamine release. And because histamine release is basically because of mast cell which releases, and specifically it depends on how fast the vancomycin dose has been given. So it is always correlated with the dose and the rate, at what rate it has been given. Ideally, the dose need to be given in children around 10 milligram per minute. And even in the neonates, it should be even slower than that, should be like around 5 milligram per minute. So it is always depend on the dose and the rate, how much, how fast, or how slow you are given. So to avoid the syndrome or the complications, you need to have a certain the rate of infusion need to be given in a certain standard. That is how it should be there. Do you want to add anything, Rovina?
Yes, our audience is very bright that they know it's histamine release, and Dr. Dilip has already pointed out the vasodilatation is due to the histamine release and it's rate dependent. And actually, the histamine release and the activation of the mast cell and basophils are non-immunological process. So it's not because of IgE mediated process, and it's not related to any complement or other antibodies. So it's a non-immunological process. So it's not the same kind of anaphylaxis as we described for IgE mediated immunological anaphylaxis. So the treatment and also the prevention will be quite different.
Yes, thank you. Thank you, Dr. Dilip and Dr. Rovina, for clarifying that it is not a true allergy or true anaphylaxis, and it's truly anaphylactoid, as we can say. So let's look into how do we prevent it. I think this is crucial for all of us that we prevent it. So let's hear from the audience. How do you think we can prevent this occurrence? For that, the panel, Dr. Serpil.
The audience is coming, giving the all the same reaction, that if we give the drug slowly and if we can give 1 cc and wait the reaction, watching it, giving it 4 to 10 minutes is the solution. So the proper dose and speed is the right answer to prevent this infusion reaction. However, there are also other very coming slow answers coming, but please try to not to give the drug concomitant with the other histamine releasing drugs we use, such as morphine or contrast media or atracurium. So we have to be careful with the other histamine releasing drugs. We can use the test dose. Yes, you are right. And please give all the drugs slowly, other than atropine and adrenaline, not to see the infusion syndromes reactions.
Yes, I guess there were 2 questions in the whether a test dose is appropriate to give, and I think the answer is yes, but how reliable it is a question. So I think we will take this a little later when the Q&As happen, because in the interest of time, we need to go ahead, but this question is noted. Okay. How do we treat vancomycin infusion reaction? So let's say it has already happened, as in this case, and how are we going to treat it? We just have 30 seconds for this. The panel here is Dr. Rushali. Dr. Rushali.
Yes, I am. I'm doing 2 things. First, the thoughts, and then the reading of what is being written here. So they have answered almost everything that I would have said. I would just put it in an order. Well, first, to prevent it, Serpil has already said that, but calculation of the dose is essential. So which is 10 milligram per kilogram per dose, giving it very slowly in DNS or NS. Treat if we know that such an incident has happened again with that particular patient. How to treat actually? Yes, first is stop the infusion. Second is stop the anesthetics as well. Bolus of fluids is already written. Antihistaminics has already been written. Let's be a bit more specific about it. So it's pheneramine maleate in a dose of 0.3 milligram per kilogram per dose. Even H2 blockers are known to be effective, but usually the H1 blockers is what I use. Epinephrine, yes. Hydrocortisone, which is staring at me on the screen, I'm not too sure whether it's recommended anymore. However, there are reports way back in 1998 that they did recommend. Having said this, this is a neurosurgery, and I guess from the nature of the surgery, from the surgical aspect, we have already given steroid. So generally, it should really respond to what we are doing if it is really an anaphylactoid reaction due to vancomycin.
Thank you, Dr. Rishali. Now, treatment of vancomycin infusion reaction, I think largely is to stop the vancomycin infusion or to slow it down and to restart at a very slow rate to begin with, to treat with antihistaminics as mentioned by Dr. Rishali, and the supportive treatment to treat the hypotension with fluids and with vasopressors. So I would quickly take you through the prone position and what are the causes of reduced EtCO2. Because an incident happening in prone position all the more is challenging, like we said. So let's think of causes apart from the red man syndrome or the vancomycin infusion reaction that happened that could cause reduced EtCO2, especially in prone. And for the panel, Dr. Vibha, please do interact with the panel.
Sure, thank you. So I really like the answers that come through, and but personally, I think I would like to divide reduced EtCO2 in prone position if it is associated with hypotension or it is not associated with hypotension. Because if it's associated with hypotension, then of course we know that when the blood pressure drops, the EtCO2 usually drops as its reflection of the cardiac output. So I think some of the causes that people have entered, like low cardiac output, bleeding, hypovolemia, even air embolism as an obstructive shock, are all along with reduced blood pressure. But what if the blood pressure is maintained and the EtCO2 drops? Here you need to focus on causes related to the respiratory system and the equipment errors. So equipment related problems, like sometimes we see condensation in the sampling lines or sampling line is leaking, kink. So these could be some of the causes. Also, the endotracheal tube, maybe the cuff is a little deflated, maybe it's slightly getting dislodged. Other respiratory causes could include, say, a VQ mismatch. There is increased dead space. So some of these causes also should be considered with fall in EtCO2.
Thank you, Dr. Vibha. I guess there's a comprehensive list of things that we should not ignore because we might fixate on one and we may ignore the other. So it's important for us to be mindful of all these as well. But at the same time, prone position itself warrants quite a number of aspects to be involved we need to think of. So let's think of, if we put a patient in prone intraoperatively, what are the precautions that we are going to take, especially to prevent harm to the patient? So, okay. I would invite Dr. Rovina and Dr. Serpil.
Wow, our participants are very, very bright, that they have already listed quite comprehensive list of items that we have to pay attention to. So I think maybe we start from the head to toe approach, and I will talk about the head side first. So when we have to turn the patients from supine to prone, we have to make sure the head is secure, and also we have to pay attention to the eyes and make sure they are free from pressure, because pressure eye injury can lead to visual disturbance or even blindness due to the fusion in the lack of perfusion to the eyeballs. And then so my tricks is I would use a mirror to check the eyes while we position the patient to prone before the start of surgery. And if possible, I know it's not possible in neurosurgery, but if possible, for example, in orthopedic surgery, I will still check it from time to time in the middle of the operation. And now we have iPhones, we have smartphones, and we can use a selfie mode to check the eyes instead of using the mirror. It's also very helpful. And also when we turn the patient or after we position the patient, we have to check the C-spine to make sure we don't have a very excessive abnormal range of movement, especially excessive flexion, which can impact the cerebral venous return and cause cerebral edema and increase in blood loss. And it can also cause cord injury if you have excessive flexion for a long time. And it can also cause problem to your ET tube if the flexion is too much. And a lot of participants have pointed out that the trachea tube, there can be a lot of different types of tube incidents, for example, kinking, dislodgement, etc. And so when we turn patient and after we have already turned the patients to prone position, we have to make sure the airway is still secured. And one little hint is we can also put a gauze roll or bite block into the mouth of the patient, especially to put the tongue a little bit into the mouth instead of letting it to come out, because especially in surgery with intraoperative neurophysiological monitorings, patients may bite on the tongue and cause significant tongue injury or tongue edema. And for the chest side, pressure on the chest or for female patients on the breast can cause direct pressure injury. And if you have a lot of paddings and rolls on the chest, and if it is too down low on the chest, it can also cause ventilation problem. Yeah, and maybe I hand over to Dr. Serpil to complete the list.
Dr. Ravina, thank you. I think almost all the complications are pointed out, and from the answers coming from the audience, nerve injuries are very important. So we have to be careful with the pressure points. And one important point is to, again, to remind that please be sure that your IV lines are secured during positioning, and also you will have poor access to your IV lines to the other side of the child. They are so small and they're all covered. If you have to give some blood or any fluids to catch up with the bleeding, and if your IV is out of the place, you will be just swelling the arm but not giving the blood. So be sure before you turn that your IVs are secured firmly and in place. The abdomen will be in pressure, so the abdomen and thorax expansion should be checked, and the pressure points and the bladder also should not be pressurized. These are the points that I will point out.
Thank you, Dr. Ravina and Dr. Serpil. So my last question to all of you before we end the case: what are your take-home messages from this simulation scenario which will positively benefit patients under your care for future? So what is it that you take home today from this scenario? And the time is 30 seconds. Okay. Slow vancomycin infusion, vigilance is the key. Yes, simulation, it helps us learn. Checklist for prone position. I mean, that's amazing. Attention to doses and the rates. Red man syndrome. Yes, we should know about it. It's a possibility that it may come because multi-drug resistance is on the high and use of vancomycin has gone up, and hence probably we may come across is a high probability. All right. So thank you everyone for your participation. I'm just going to take you to the learning objectives that we had planned for all of you. Is vancomycin infusion reaction is anaphylactoid and infusion rate dependent. The initial resuscitation in prone position during critical incidents is crucial, and prone position challenges in anesthesia are multidimensional. So I'm happy to see that the take homes do match with the learning objectives. And that is the end of the first presentation. What I would like to do is take you to case 2 directly, okay? Because in the interest of time, let's quickly start our second presentation, okay? Oh, sorry. All right, so here we go. Sail smooth through a nightmare. This is our case scenario 2. The nightmare word is scary, but yes, we all have gone through. And today's theme is neonatal difficult airway management. Okay. So an instruction again, please do scan the QR code and enter this new numeric code 32006082. I will be showing the QR code at the end of every slide so you can see it again. So it's a neonate who is day 0 life, born at 37 weeks, 1.9 kilos, an IUGR baby with a small stomach bubble. The ABGAR score was low, polyhydramnios, and born with fetal distress. A crash C-section was done. Suspected bacterial syndrome, tracheoesophageal fistula with esophageal atresia, imperforate anus, posted for emergency thoracoscopic ligation of tracheoesophageal fistula. Anastomosis is planned with sigmoid colostomy. The echo shows an ASD secundum, left-sided arch as well. At present on CPAP and FiO2 of 0.3. Okay, so this is our case for today. Let's see how did it begin the day for Rovina. Hey everyone, how did you feel as an emotion while you're watching this video? I think the question is coming back to you. Okay, no, I'm asking about the emotion. What is it that making you feel? We'll come to the case scenario later, but I just want you to tap what emotion is that you're feeling. Yes, of course, as you see, all these emotions actually can truly impact us, especially in this situation where we want us to think straight. Okay, so this mindfulness activity to name your emotion and say it's okay to be scared, it's okay to be stressful, will help you break through and help you think rationally again. So let's look at what went well. Okay, for the morale of her team, it's important when we debrief to look at what things did we really get right, even if it was a crisis. Okay, there's good communication, the airway and the breathing management, yes, prompt chest compressions, the team leader was calm, there was a clear team leader, brilliant, yes, there was one person leading, okay. There was no panic, they were thinking as they were going. Ventilation was possible with bag mask, yes, that's our rescue, I'm sure. All right, in the interest of time, I'm going to take you to the next slide, okay. What were the challenges that the team faced in the scenario? Think of challenges from individual, as a team, as a system, as a patient. The baby was a newborn, day 0. Yes, airway was one of the biggest challenge. Multiple congenital anomalies was a challenge. Okay, tracheoesophageal fistula, it was sudden. It was a sudden desaturation, sudden arrest. Okay. Probable pulmonary hypertension. Yes, there are challenges which are in number here. Now, we are going to go to the next slide, thinking what were the causes of the challenges that came. Of course, challenges came, we did fine, but let's discuss of the differentials, what brought the challenges, okay? And for this, the panel is Dr. Rovina.
Yeah, I agree that it may be a tube displacement to somewhere that we don't want it to go. Can be this large, can be going to the fistula because it's a tracheoesophageal fistula, and congenital anomaly. I would like to know more about it. Perhaps I would see more answers. And actually, we can also consider whether it is due to pulmonary hypertension of the newborn. Yeah, when you have significant pulmonary hypertension, especially when you stimulate the airway, you have something that makes the baby unhappy, then the pulmonary hypertension can be worsened, and then it can also cause the absence of CO2. Yeah.
Absolutely. I think, Rovina, I guess our participants are thinking on what the possible causes of the challenges are. Am I right? I think let's take them to the next slide of truly giving them what happened ahead, okay, to help them even zero on certain aspects. Okay, so I guess let's talk about how to deal with this situation. So now that you know that the tube goes in and the EtCO2 is lost, Okay, the bag mask, fortunately, is here. So I would request all the participants to keep typing how we are going to operate, how we are going to deal with. By the time I invite Dr. Rushali to, give her points on the intubation has failed twice. Okay, I mean, that's like a challenge that can happen. How are we going to deal with this?
Yes, we are here with a situation which actually has one blessing and another is actually a curse. So the blessing is you can ventilate by a mask, which is a big blessing. And I guess nothing is ever lost if we are able to ventilate via a mask, especially in this kind of a situation. The worst part is the tube is actually going through the cords and giving us an illusion that we are able to ventilate, but we can't ventilate. So let's go back to something called as dope. What is happening is either the tube goes via the larynx and is getting dislodged somewhere or displaced inside out there, or then there is obstruction to the tube, or there is some pneumothorax, or there is an equipment malfunction altogether. So I guess what we could do is we can really channelize our thinking. But at the current time when we cannot put in a tube and we are repeatedly failing doing that, we should continue ventilation and perhaps think of some other way of maintaining the airway, perhaps an LMA. And while I said that, I just read insert an LMA in front here. So let's go by.
Thank you. I guess because bag mask ventilation was our only savior, I would invite Dr. Vibha to just talk about how to optimize bag mask ventilation. I mean, that's something that we rely on.
Absolutely. I think we rely on bag mask ventilation when there is a difficult intubation. But what if we are not able to bag mask ventilate? So I think we need to optimize the bag mask ventilation. And there is a cognitive aid by the name of MR SOPA that can actually be run through while we are trying to optimize the bag mask ventilation. I think we have a video on MR SOPA. So
yes,
I think we'll see it together. Yeah, sure.
Absolutely.
Now, I guess I hate to say this, but I mean, being a lead, I need to do something unpleasant things also. We need to be very mindful about the time that is happening. So,
yes.
So let's be a bit more cautious about that.
Absolutely. So just a quick input from Dr. Serpil regarding the LMA as a rescue device as per the difficult airway guidelines.
Sure. After bag mask vaccination, LMAs has its place in difficult intubations and difficult ventilation. So if you are anesthetized enough, if deep enough, so you can use LMA properly in these cases as well.
Yes. So I think LMA is something that we advocate to be kept as a rescue device. And
you should be ready for all airways.
Right. Airways. And Rovina, do you want to add anything about the infant feeding tube? Just a quick mention.
Yeah, if you have bag mask ventilation for a period of time, or you have inserted an LMA successfully ventilating the baby, but the stomach gets inflated, and then it would also cause impairment of the ventilation. So you may consider inserting infant feeding tube or whatever gastric tube. But yes, for this case, it's quite special because it's an esophageal atresia. So you may not be able to reach the stomach when you put it through the mouth. Then one point is you may discuss with surgeons whether there is a need to get a gastrostomy to deflate this if the ventilation is impaired.
Absolutely. Thank you, panel. I think what they mentioned was about a mnemonic called DOPE, where post-intubation hypoxia or deterioration could be ruled out with this cognitive aid, where D is for dislodgement or displaced tube, O is for obstruction due to kinking or a mucus plug, P is for pneumothorax, and E is for equipment malfunction. So we go through a check, and as we can see here, largely our case revolves around the D, that the tube is not in the trachea. Okay, so that's something that is causing trouble. But at the same time, our bag mask is effective, but to keep it effective, we need to know a mnemonic or a cognitive aid to optimize it, which says MR SOPA, Mr. SOPA, M for adjusting the mask well for a good seal, reposition the airway, suction the mouth and nose for secretions, open the mouth slightly by moving the jaw forward, use the pressure to achieve chest rise because it's day 0. There would be chances that the lungs are yet not recruited, and consider alternate airways such as intubation or LMA. I guess all of us have thought of video laryngoscopy as a first choice because it's available in most of the urban setups. So Dr. Dilip had done a video laryngoscopy for this patient. So let's see what he saw. Dr. Dilip?
Mask ventilation was possible, and the most important thing, mask ventilation is good. So what we can do is that instead of doing a classical intubation, so we should have a video laryngoscope. And when we did a video laryngoscopy, you can see there is a complete glottic closure. So first thing what we came to know that the glottic closure is there and the tube is going below the, it is going into the esophagus. So this we came to a conclusion. So again did a mask ventilation, and then what we did in this case was like we did a tracheostomy, and then we did a bronchoscope, and then we can show you the video of like how.
Yes. Yes, I guess because there was a clear indication that we could not really put in the tube. The decision to put an LME was taken to think of a definitive airway to be performed and to be prepared. So let's quickly revise. How do we go ahead?
Now the team will insert a laryngeal mask that does have an inflation cuff. This mask also has a gastric port that allows insertion of an OG tube after the laryngeal mask is in place. The team is ready to insert the laryngeal mask. Quickly inspect the mask and ensure that all the material is intact without tears or kinks. Attach a syringe to the inflation port and completely deflate the cuff surrounding the mask. Maintaining tension, disconnect the syringe. Stand at the baby's head and position the head in sniffing position. Hold the device in your right or left hand as shown so that during insertion, the hard part of the curved tubing will slide along the hard palate. Gently open the mouth and press the leading tip of the mask against the hard palate on top of the tongue. While maintaining pressure against the palate, advance the mask along the contour of the mouth and palate until you feel resistance. Inflate the cuff to achieve a seal. The device may move slightly outward when it's inflated. Assess inflation by feeling the pilot balloon. Never inflate the mask with more than the manufacturer's recommended volume of air. Attach a PPV device and CO2 detector and begin PPV. Assess for chest movement and equal breath sounds. If ventilation is successful, the heart rate and oxygen saturation should increase. By the time you've given 8 to 10 breaths, the CO2 detector should turn yellow as it detects exhaled CO2. Secure the laryngeal mask and monitor the newborn's heart rate, oxygen saturation, breathing, and muscle tone. This laryngeal mask has a port for insertion of an OG tube. Measure to determine the correct depth of the OG tube and insert it down the port. Aspirate the air and stomach contents and leave the tube open as a vent.
So like Dr. Dilip said, after LMA was secured, a definitive airway was planned and a surgical tracheostomy was performed to secure the airway. The child was out of the crisis, but what should be done next? I mean, why did the crisis happen? Where was the tube going? Is a question in everyone's mind. Do you have any suggestions? I just give 10 seconds for this to the participants. What should we do next? Probably in the fistula, yes. What should we do next? A rigid bronchoscopy, yes, absolutely. I think that is what was done. A bronchoscopy was done, and this is what Dr. Dilip saw.
Yeah, so this was the bronchoscopy what we did, and you can see your nasogastric tube, and then you can see the fistula now. So almost this is the tracheostomy tube. So almost there was around 1.5. This is the tracheal tube you see here, tracheostomy tube. So almost there was around 1.5 of the tracheal. So there was a laryngotracheal fistula. So right from the larynx till the tracheal end. So exactly we did a tracheostomy just above the carina, and you can see a much fistula was too much more wider.
Yes, absolutely. So what he's saying is it was a laryngoesophageal cleft. Okay, not only the tracheoesophageal, but a laryngoesophageal cleft, and that is the reason the tube kept slipping. So there are many types and extent of the laryngoesophageal clefts, as we can see here in the picture. Fistula that is cannot benefit from tracheostomy. The tracheostomy was done quite lower down, as it was shown. Also, these are the video laryngoscopic views which are possible, and a cord spreader is required to spread the arytenoid cartilages to see the extent of the cleft if it is not evident classically. But yes, it is something that is varied as a picture, and we need to be vigilant. So after 4 or 5 days, the baby underwent a surgical closure of the tracheal cleft, and he's already 4 years old and healthy. I would like to thank you all, but before that, I would like to know what is the take-home message today from this session that will benefit the patient under your care in future? What is it that you take home from this simulation, this case scenario? Optimize bag mask, be prepared, importance of syndromic patients, anticipate ED tube placement in tracheoesophageal fistulas could have a laryngeal component as well. Keep laryngeal cleft in mind.
Yeah.
Absolutely. Thank you so much. Thank you. Learning objectives of this simulation for all of you were anticipate the laryngotracheal anomalies in neonates with congenital syndromes. Be aware that larynx may be involved too. Dope as a cognitive aid to rule out differentials of hypoxia when an advanced airway is in place. Prioritize and optimize oxygenation by bag mask and use MR SOPA as a cognitive aid to do so. Use LMA as a resuscitative supraglottic airway to oxygenate till a definitive airway is secured. Use advanced gadgets such as video laryngoscopy or bronchoscopy, if available, to rule out the cause of the problem. So, how was your experience of learning via virtual simulation? Could you just let us know the experience of learning through simulation on a virtual platform? Thank you. Thank you so much. I think these words are, making it worth for our effort that we have taken in the past. And I guess the panel as well is quite happy to see them. But I do have a question for all of you before we part. In future, would you prefer a didactic session or a virtual simulation to learn about case management, a case-based discussion? Okay, so 39 participants. I think if we all can give your comments, it will help us to plan for further education activities using didactic, virtual, or maybe both for that matter. Okay, so thank you, everyone. Thank you for a wonderful session. I hand over the baton to Dr. Rushali Ponde.
Well, profuse thanks for you, Vaibhavi. Very smoothly conducted. And of course, the Q&As, they poured in and we have answered them there and then. So I guess now the box is vacant. So let's go ahead and let me do
I'm sorry. We have a couple of questions that I answered that we will do them live because we had moved ahead in this scenario. Could we just quickly, do you want me to look at them?
Sure. Okay, let me know what they are, because I guess we typed them quite So I typed the answers for them, but shoot, go ahead.
One is from Dr. Rebecca and some other audience. Does LMA Supreme have the proper size for neonates? And the size for LMA is a question. Do we have proper size for neonates or small babies?
When anybody wants to take this question to answer, because we use LMA Supreme 1 for neonates. Yeah, Dilip, over to you.
Yes, we do have so usually we prefer a Supreme LMS because they are most reliable and very useful thing. So second generation LMS are available, Supreme LMS are available for the neonatal age group also. So that is a size 1. And then so on 1.5. So below 5 kg, then 5 to 10 kg, and then 10 to above. So that is how the sizes which are available. So yeah, definitely neonatal size are available.
And Dilip, this is how actually you have managed this given case, right?
Yes, definitely, because till I came there, I told my colleague to insert an LMA, and believe me, LMA saved this child because they were able to ventilate, and the mask ventilation was also possible, but how long to ventilate? So, and then we did a tracheostomy on a LMA, and we move ahead with the further management of the case.
Yeah, so Dr.
There's
Dilip,
one
there
more
is a
question. Oh,
yeah.
sorry.
I was also coming to the question.
No,
I was just saying, Dr. Anjali had asked, how was the patient breathing, or why were you still able to ventilate when there was complete laryngeal closure? Dr. Dilip, do you want to answer that?
Yeah, because there was a fistula, so the cleft was there. Through that cleft, the ventilation was possible. So though we could see that there was a complete glottic closure, but just below the glottic closure, complete fistula was there. So the ventilation was possible in this child.
I want to add also, other than LMA Supreme, AirQ has a smaller size, 0.5. So it's more proper and a good size for the neonates and small babies. And there's another question that, will it be safe to go for the surgery with LMA?
Well, not really, and that explains why a definitive tracheostomy was done. So LMA is only a stopgap arrangement in this particular situation. So are we still with any interesting questions coming up?
I think all done. The surgical airway is the safe one. We had answered that. And Rowena, do you want to say? I think you had raised your hand, so it's okay.
So could we go to the next slide in that case, Vibha? Do I have the permission? So these are the references that we have based our talk today. And now there is one more amazing news that we have. It's all over the web, but I want you to note that ASPA 2023 is here to welcome you to Korea. They have put an amazing scientific session, and of course the venue goes without saying is wonderful. Please note the dates. The last day of early bird and abstract submission has been extended till 30th of April. So please do make use of this opportunity, and here is how you would register. This is just a glimpse of all that is put up for you, and choose the topics that you wish to attend. These are the registration details, but of course it is all here on the website, just in case you really cannot register in your mind because the slide looks very busy. This is to give you an idea, and of course the glimpse of the location and what is there in store for you once you visit the place. So we look forward to see all of you here. Now a few words on ASPA again. Well, ASPA is empowering through education. As I told you, ASPA's mission is to foster the highest standards of pediatric anesthesia care in entire Asia, and it is a non-profit organization. Hence, we seek your help to donate and help us in our cause. And in any ways, our cause is a cause and we are going ahead with it. Thank you so much, but much would be appreciated if we to get back. Thank you so much. And I have thoroughly enjoyed this webinar, and I wish all of you had. The last slide assured me that you all have. I guess from all the participants, there were hardly any who weren't putting up their words here. So they were all pouring up. And yes, I can see the satisfaction on Vaibhavi's face. So that is keeping my heart extremely excited. Thank you, Dilip. Thank you, Rovina. Thank you, Vaibhavi. Vibha, your par excellence, you have toggled two aspects, panelist and the IT support, amazing. And you are so flawless in handling the mente and the people and the stillness that you have in you to wait for the answers to come. Vaibhavi, hats off to you. And Sarpil, my friend, thank you so much for being here. And thank you, audience. No matter what we do with academics, if there is no learner, I don't think anything works. We are underestimating a learner a lot, and we each one have a learner in us. So thank you so much. Once again, thank you. Thank you.